Thank you and good morning to all of you. Thank you Dr. Devan and also the AOS for giving me this opportunity to be here. So the topic is, does a family history of glaucoma justify the treatment? I don't have any financial disclosures. If you take primary open-angle glaucoma by 2020, we'll have about 59 million people. And if you take angle closure, it will be around 21 million people. But if you just look at the ratio, primary open-angle versus angle closure disease, it is 3:1. But the rate of blindness is 1:1. That means there is an increased evidence that angle closure glaucoma has 3-fold increase in the risk of blindness. There are various risk factors involved in the development of glaucoma. Of course, one of the major risk factors is having the family history of glaucoma. It has been reported in about 18 to 25% of the cases. There are various genetic locus have been identified for primary glaucomas, primary open angle as well as angle closure disease, and also congenital glaucoma, normal tension glaucoma, pigmentary glaucoma as well as the pseudo-exfoliation glaucoma. These are some of the genes which has been already been isolated for open angle glaucoma, normal tension glaucoma, pseudo-exfoliation, pigmentary glaucoma. When you're looking at the exfoliation glaucoma, it is one of the most common type of secondary glaucoma, which is prevalent in more, of course, in South Indian population. I'm not sure how much is in the North Indian population. But there are two main sites of the gene is called as the LOTS L1 gene, which accounts for about 99% of the patients. And this may be looked for the future genetic therapy. When you're looking at the angle closure glaucoma, we all know that primary open-angle glaucoma, we have about 15 genetic locus has been already identified. But if you look at the PACG, the genome-wide association studies, they have identified about 3 susceptible locus, RS102, 841 and 213. The most common subclinical types is open-angle glaucoma and the angle closure. Of course, there is always an enigma in the angle closure because the phenotypic presentations are quite varied in the angle closure disease. So only the locus has been identified now. So of course we all do the family screening for at least not every glaucoma patient, but family screening is important. You can see why we have to do a family screening. The relative risk of developing primary open-angle glaucoma in a population with family history is 9.2, and which could be, you can see that 5 to 20 times higher than the population prevalence rates if you have a family history. So there are racial differences, environmental factors, frequently reported family history suggests a genetic basis for the disease, which is obvious. And about 5% of the primary open-angle glaucoma results from mutations in the myosin, that is MAOC gene. And also they have seen that the gene studies have shown that Afro-Caribbean adult populations show about 7% and also 8.8%. This is a particular study done at Arvind Madurai to determine the prevalence of glaucoma among the family members in the primary open-angle glaucoma. So a prospective study done in 2007 to 2009. It included 514 patients. Of that, you can see about 68 patients had definite glaucoma. And JOAG, PYG suspects and ocular hypertensives were also there in that group. The mean age in that particular group of the patients were 56 or 57, we can say. The siblings attending the screening were closer to 50 years. The definite glaucoma group were 56, and the mean age of the glaucoma suspects were a little younger, so it is about 50 years. You can see in this, the siblings had the highest in prevalence rates, 7.97. The suspects were a little less because we know the siblings had almost closer to that same age group. Offsprings had the lowest incidence of prevalence of definite glaucoma, but they had the highest prevalence of glaucoma suspects, and parents were in between 3.8 and close to 4%. So this study has shown definite evidence that the siblings had the highest incidence of having the primary open-angle glaucoma because of the closer genetic makeup and perhaps a similar environmental factors during the childhood. There are several association studies have been conducted for candidate genes, and genome-wide association studies have been identified, especially for POAG, namely the S1 RNA, caveolin 1, 2, and the cyclin. There are various S1, X1, S1, X6. I'll just there are other studies like Rotterdam study, Baltimore Eye Survey, Barbados Eye Survey, all these things have shown that there is increased evidence of having the siblings have the highest incidence of glaucoma than the offspring of the parents. In a nutshell, in a primary open-angle glaucoma, the Indian population has also a very high risk of primary open-angle glaucoma. The risk definitely increases with the age, but of course in this particular study the age group was little on the lower side. And there is no definite data, the published data to support the early treatment in ocular hypertension or primary open-angle glaucoma suspect, considering only the familial predisposition. So that is very important highlight I was showing you. This is coming to the angle closure disease. This is another study again done at Arvind, Pondicherry by Venkatesh et al. To determine if siblings of patients with various stages of angle closure glaucoma have an elevated risk of angle closure disease. So this study included about 81, 304 sibling pairs, including 81 with the open angle, and then 46 with angle closure suspect, and the remaining were with the angle closure and angle closure glaucoma. The results, you can see that the angle closure was prevalent in 3.7% of the open angle siblings, 36% with angle closure suspect siblings, and 36.4% of angle closure and angle closure glaucoma siblings. Just to conclude that the siblings of angle closure have greater than 1 in 3 risk of angle closure in at least one. You can see this chart. You can see that about the open angle about 3.7, angle closure suspects having more angle closure suspects, but the primary angle closure and primary angle closure glaucoma will have higher incidence of primary angle closure and primary angle closure glaucoma as well. So this is the genetic evidence from the same study. So it has shown that among the 3 studied single nucleotide polymorphisms, there is a significant genetic association was identified in RS213 in the PAC and PACG group. So there is a very strong evidence to show that. There are other studies. The name is ZAP trial also has shown something similar to that. The prophylactic laser iridotomy in high-risk angle closure suspects, but unfortunately the familial predisposition was not studied in this particular study. This is another study from Ronnie George et al. From Netherlands, showing that whether the laser PA in primary angle closure suspects is useful to prevent the angle closure, acute angle closure glaucoma. But we can see that about 28% of these patients have progressed to primary angle closure. That means there is a definite evidence to show that if you do the PA properly, you can prevent the acute attack in quite a good number of patients, but that is not been studied. But this is an indication. Once you have the primary angle closure development in 28%, that means there is a possibility that they could have developed. Just to say precisely, still it is long way to go for genetic mapping because it is very extensive procedure, time-consuming procedure, and there are a lot of phenotypic presentations, very phenotypic presentations. So it is quite difficult for us to understand the whole thing. But there are several ways how we can treat this. One, there is no need to treat this if you have family history. There is a definite treatment required, and there is a treatment in decisive group. This is the last slide, which shows that there is no treatment required in the group where everything is normal, so you don't have to really treat even if you have a family history. But if you have any evidence, then possibly you have to treat this group. And there are groups where there is still indecisive treatment is ocular hypertension, but there is no strong evidence to show. PACS, yes, there is some evidence, 1 or 2 studies, there is some evidence. Probably if you do PA, you can prevent to an extent. Normal tension, POAG suspects, still there is no strong evidence to treat these patients just with having a family history. Thank you.